So how to marry implementation and science? Yeah, I think in many projects, and we're just finishing a project, a European project on cardiovascular prevention in marginalized areas, where that comes up all the time. There's a tension between implementing stuff, getting stuff out there, and evaluating it. Yeah, a lot can be said about it, so I won't talk too long, but about 10, 12 minutes. How to marry the two. So I'm from the Brighton Sussex Medical School, the Department of Primary Care and Public Health, and I work for a large part of my week for the Applied Research Collaboration Kent, Surrey and Sussex, which I think is going really well. So we're really happy, and it's a really nice regional collaboration. So this is the website. I put the address at the bottom of the website of this page. So you can see on this website what it is that we do. Loads of different types of projects are going on. It's basically an infrastructural resource. So we are intended, I think Mel in the presentation this morning called it an orchestra. We're intended to sort of start an orchestra. I hope the orchestra will play nice music at some point, but that's something for you to decide. So learning outcomes for today, for my brief talk, well, what does the science of implementation actually mean? First, so if you look at the literature, for instance, there's a very nice journal called Implementation Science, led by Paul Wilson from Manchester, my good colleague. I've worked with him for quite some time. And a paper called the STAR-I framework, Standards for Reporting Implementation Studies. I'll get back to that. It's much more about strategies than about interventions. You know, psychologists or social scientists love interventions, doctors as well, of course. But this is more, okay, how do we get it into practice? How do we get it on the shop floor, so to speak, rather than an intervention as a single thing that can be randomized in a randomized trial, etc. So it's about introducing, like Sam said, introducing real world stuff, getting people to use it, getting it to be sustainable, become sustainable, and evaluate it. And but that can create tensions because, for instance, our strategic intervention to introduce cardiovascular prevention in marginalized areas, who owns it? How can it become sustainable? I'll show you the slide later on. So our overall focus for the ARC is to focus on social care and social health issues, and I think particularly, and Sam's mentioned that too, marginalization, vulnerable groups. So this session is very much about how a problem within this remit, within our ARC, could be translated into a research question that could be answerable. I nicked this slide from you, Sam. I think I like the owl. So why is implementation science important? Of course, yeah, it's sort of straightforward, of course. So it helps the system to prioritize. It helps purchasers of care, social care, healthcare to provide new interventions if they work. It helps providers to make decisions about the type of stuff that they want to do. It helps asking the right questions. We talk a lot about costs in implementation science, of course. What does it cost to do something? Does it align with delivery models? And I can give you an example from an ongoing project. There's loads of digital tools, for instance, for back pain. And there's good evidence that they work. They do large trials. But if you look at all the evidence or all the use rates for such interventions, nobody uses them. So there's an interesting dynamic between evidence-based, the evidence base and the real world. How can we make sure they are used? So as I said, this is a STAR-I paper by Hilary Pinnock et al. In 2017. And she wanted to sort of draw a framework for implementation science, implementation studies, which is in the top right quadrant. So you have all these, and this is mostly about interventions, by the way, but you have all these studies about efficacy, effectiveness, does it work on the real world conditions? And then you start towards sustainability. Will this stay around? Will this intervention, will this package or strategy of implementing something, will this actually be sustainable? So for the ARC, we chose a place-based approach. to implementation. So that means we try to establish communities locally, regionally, preferably work on optimizing our relationships with marginalized communities. In terms of methods, research methods, we will probably focus on qualitative methods initially, process evaluations. This is a very nice framework called the Consolidated Framework for Implementation Research. Have a look at that. It's a very nice website with very detailed type of questions about these, for instance, these 5 issues. Reach. Who do you reach? That's an important question for digital interventions, for instance. People with no access to a mobile phone will not be able, we won't be able to reach them. Is there evidence for effectiveness, adoption, implementation, maintenance? That's another nice framework that we use a lot. It's called the RE-AIM framework. So if you're starting in implementation research, have a look at these websites and resources to start your journey into implementation research. So as Sam already mentioned, the ARC is an interesting collaboration with the Academic Health Science Network. I think we're unique for that. So you can see Sam at the bottom here, between all her wonderful colleagues. The ARCs are a collaboration between the NHS and social care and universities, which means there's both an emphasis, and that's also the attention of this talk, between implementation and science. So we do a lot about implementation, but we also need to think about, okay, how do we evaluate? This is just one more slide I nicked from Sam about diffusion, dissemination, and knowledge mobilization. I think the third one is the most active one. And as an ARC, we try to do a lot around knowledge mobilization. Medically, what happens usually is that new knowledge, new science is translated into guidelines, and guidelines are implemented. That's a common medical improvement pathway. So this is what we do to meet the needs of local populations and systems and apply solutions. This is an example of a project that's quite specific. You can look it up, the Healthy Hearts project that we developed around cardiovascular prevention for marginalized communities. It was quite a difficult task, especially in COVID. But this is actually still out there, and we're trying to figure out how it can be made sustainable, how people can keep using it. So what are our outcomes? As a group, this is the digital and primary and community health services outcomes. Of course, we started with looking at governance, getting to know each other, employing staff, situational analyses. So now we're working on multi-theme projects. I'll get back to that in a second. Around aging, readmission, deprivation, etc. And hopefully in a few years, we can get the second ARC, it's a 5-year grant, as an important outcome. So these are our 8 themes. The first one is social care, starting with young people, dementia, primary community care, co-production, public health, digital, and the last one is economics. So the project that Ayse is just now going to talk about fits almost all these ARC themes, except perhaps the second one, which is the young people box. But another project we're starting with called Catalyst is about young people's mental health. And that doesn't tick the dementia one, but we try to set up projects that tick every box in this table. So I think it's about 10 minutes now, yeah. So Ayse will present, I think, an example of how you do, as a PhD student, how you start doing this kind of implementation science about, in her case, older people using healthcare technology. So it's all about evaluating and about improving, but also about implementing.
Okay, so I'm Ayse and I'm an ARC-funded PhD student at the University of Surrey. And my PhD project is around reducing digital disadvantage in older people during the COVID pandemic. and how the role of like families and carers can be used to increase their technology acceptance and usage. So just a brief slide about me. I graduated with an undergrad in psychology, then went on to do my research methods, MSc, and then started at Surrey. For this project, I'm doing a mixed methods designed to hopefully explore the topic. And at the moment, my plan so far is my metaethnography. So I'm going to be presenting my preliminary findings. And then I've got a paired interview study in the line, and then my participant observation study. So to start off with, I conducted a qualitative synthesis, which is still ongoing at the moment, using metaethnography methods, and my question being, what are the determinants of older people adopting communicative e-health services? So since the pandemic, a lot of our everyday life has turned into the online world. This is including like a lot of aspects of healthcare as well. But there's quite a lot of groups that are still digitally disadvantaged, and they experience digital inequalities, and older adults being the largest group to experience this, especially in the UK. So this increase in digital technology can be quite problematic for these sort of people, and can reduce people's access to different facilities. A recent paper actually showed that GPs reported that there was an increase in video consultations, but older people tended not to use them. So this is potentially hindering their access to basic healthcare needs. So my aim, therefore, is to explore people's perceptions and or experiences of communicative e-health services, and then from them to identify facilitators and barriers of these. So I conducted a systematic search using terms relating to older adults, e-health, technology and communication. This diagram, I don't know if you can see it all, is basically to illustrate my inclusion and exclusion criteria. So I was interested in both the asynchronous and the synchronous types of communication. And in my research, I've defined communicative e-health services as any service a patient receives online with them actively interacting with a human. So like online video consultations, emails with healthcare professionals. You'll see later on that that includes like text messages as well, and like WhatsApp. So my screening process, so there's 2 researchers involved in our screening process. Our initial search yielded over 10,000 results, but after the whole screening process, only 8 were eligible. It's quite interesting actually, because out of the 8 papers that were eligible, only 3 of the papers had participants in there that had actively used communicative e-health services. So that was all the experience. The rest of the papers were just perceptions of it. No one had actually used any of the communicative e-health services. And also interestingly, I think 7 of the 8 papers were all published after COVID as well. So I reckon like COVID had some sort of influence in them papers. So like I said, despite over half of my papers having participants who had not used communicative e-health services, a lot of the findings were very similar across the papers, and their interpretations from the older people were shared. So these are a few of the experiences / perceptions. And then I have some quotes that are taken directly from the papers. So people spoke about how they could use the communicative e-health services in their own time, and that it'd be good to use abroad. Like I said, a few people spoke about using WhatsApp and said it was quite effective. But a few people in the papers mentioned that it was a waste of time really, because they still had to go into the practice to get some tests done, like blood tests done. So it just seemed a waste of time having the online and then having to go in. And the biggest thing that we found as a positive was that the support from children and spouses, like that was a shared thing across all the papers. So again, despite the participants not having used some of the e-health services, all the facilitations barriers were quite similar as well. And then I've got some more quotes. So it was quite vital to have some sort of support when setting up the e-health services. So it's available, but there's no support with setting it up. So they found it quite difficult and unclear. The instructions weren't very clear. A few people said that they weren't interested at all in using communicative e-health services. The face-to-face was preferred, and people said it was more personal and the doctors were able to see them and touch them. And again, clear instructions. I think one participant mentioned that they kept getting logged off for some reason, and that it becomes quite frustrating if you can't log on to something that's meant to be quite easily accessible. So from the findings that I've made some suggestions and guidance for the public to use to help increase the usage and acceptance of e-health services amongst older people. So the main one obviously is supporting older adults. That came across all papers. I think that we should be able to support like all our like families, friends that are struggling with this. Spreading awareness as well. A lot of people aren't aware of the applications and services that are available to use, so then they miss out on that. Promoting stronger relationships with clinicians. So I found in one of the papers that people are more likely to use the communicative e-health services or just general e-health services if they had a good relationship with their doctor, and it was the doctor that was the one that was promoting the e-health service. Assistive technologies as well, so making it more accessible to people that have physical difficulties, using technology such as like speech to text recognition. I think some people said they had issues with like their hands and not being able to write things quick enough. I think actually the main one, this one, is increasing people's basic digital skills. If you can't use your like smartphone, tablet, or like a laptop, then you're not going to be able to use any e-health service online. And then finally, making sure all the instructions are clear, and we're making the interface of any e-health service as simple as possible. Like there's no need to make it too difficult. So for me, this is how I'll be applying my findings from to my future work. So a lot of my findings will inform my interview questions for both of my paired interviews and my participant observation study. In particular, my participant observation, I'll be volunteering as a tech angel to support older people to increase their digital skills. So I'll be making sure that when I go into people's homes and teach them how to use a tablet, I'll be providing like clear instructions, writing things down. If they have any physical difficulties, maybe suggesting an assistive technology or an additional thing like a pen to go with their tablet. And also making people aware and promoting different applications which they may not know, and it could benefit each individual. And I think finally, I think it's important to consider the ethics surrounding this big increase in digital technology. So are we as a society right now being forced to use digital technology just to access basic things such as healthcare, education, like social housing? And do we have autonomy over whether we want to use technology? And if so, what we want to use it for? So yeah, thank you for listening. I actually am presenting my poster on this topic at another talk later on this week. So there's a QR code if you wanted to see the poster.